So, everybody knows the definition of pain, right? What is it?
Whatever the patient says it is.
Yay! It's complex, multidimensional, and is often the main reason people seek medical care. Why are you here? This hurts. Why are you here? This hurts. Why are you here? Right? Something's hurting. They want to seek care. We already said it's whatever the patient says it is, existing whenever they say it is. Another definition that people have used is and this is like the really super technical one. You don't have to write it down if you don't want to, but it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It's what the patient says it is. There are special populations, right? So if it is whatever the patient says it is, what about the patient that's in a coma? Can they tell you they're having pain?
No.
Do they still experience pain?
Yeah.
Yeah. So how do we treat that? Or the patient with dementia that can't remember or may just not be functionally there? What about end of life? What about people with substance abuse? Are we all a little hesitant to provide pain medication for those who are IV drug abusers? So a lot of times we have to treat them using nonverbal information, right? If they're grimacing, how they're looking. And we have to treat patients who are in comas or who have dementia as though they're awake. We still have to treat them. We can't just say they're in a coma, so I'm not going to give pain medicine. If I see that they're grimacing, if I see that they're posturing when I do something to them, I'm going to treat them for pain. I'm also going to have to treat that substance abuse, patient that I'm not real excited about because I know they're here for endocarditis because they're an IV drug user, and now I have to give them pain medicine, which is why they got themselves there in the first place. It's still our job to treat the pain. So, why is this such a problem? And I'm going to go over this part kind of quickly. There's unnecessary suffering happening, especially when it comes to our special populations. It can cause that physical and psychosocial dysfunction that we talked about. Immunosuppression, and the psychosocial model of pain. That's all in your book. I'm not going to go too much into it. You guys can review it if you'd like. But the biopsychosocial is all that physiological, affective, cognitive, behavioral, social, economic. Just talks about the magnitude of the pain problem and how it causes financial stress on us, psychological stress on us, all that. I don't have a table number or pages. All right, how do we classify pain? We classify it by the underlying pathology. So, is it nociceptive or neuropathic? So, 1 by the pathology, and then 2 by the duration. Is it acute or is it chronic? So by the patho and by the duration. So we're going to go to nociceptive first. All right, that's one of the ways we classify it. This is some kind of damage to somatic or visceral tissue. A surgical incision, a broken bone, arthritis. How do we treat it? Opiates and opiate medications. Now, I told you all I typically color code these first two lectures because they're just kind of broad and don't talk really about pathophysiology. They're not going to be color coded. It kind of bothers me, actually. I might go back and fix it. So nociceptive, there's some kind of somatic or visceral tissue that's damaged, and we treat it with opiates and non-opiates. We're going to get into it. Somatic is localized. So somatic pain is a nociceptive pain. It's just local. And it can be superficial, where like I cut my skin, so it arises from the skin, the mucous membranes, the sub-Q tissue. So superficial. I fell and busted my lip, anything like that. And people typically describe it as sharp, burning, prickly. Think about that time you accidentally cut your, hand with a knife. I think almost everyone's done that, right? It hurts. Even a paper cut, they hurt. And you can visualize that, or you can kind of remember that it was sharp. If it's deep, it's going to arise from a bone, joint, muscle, connective tissue. I just did Orange Theory for 2 mornings in a row, and I cannot sit on the toilet because my thighs are on fire. Okay? I would just classify that as a deep pain. So I really had to hold on to something to get. I have a lot of lactic acid buildup. And people describe this as kind of an ache or a throb. It's not really sharp. It can be, but, and again, things can kind of, this is not always black or white or definitive, but they're generalizations for most people. Visceral has some kind of tumor involvement or other kind of obstruction. So it arises from the internal organs and like lining of the body cavities, like your abdominal cavity or your thoracic. So somatic is localized, it can be just superficial or deep, where visceral is from organs. If you have to make yourself a table, I believe in the module there's a table that goes and can show you the difference. So even if you don't like this way of lecture, pull out your module and we're following right along. You can fill it in. And it's a response to any inflammation, stretching, ischemia. And people describe it as like an intense cramping pain. What you're going to experience after today's lecture writing. All right. So nociceptive, what is it? It's either somatic or visceral, right? It's some kind of damage to tissue, and we treat with opiates and non-opiates. This is different from neuropathic. Does your module want you to know the difference between neuropathic and... Yes. This is damage to the peripheral nerve or the central nervous system. So unlike damage to your skin or an organ, this is the nerves. Nerve type pain. Think of that. People describe it as being numbing, hot, burning, shooting, stabbing, electric. Think of nerves. Those are all words I would think of when I think of a nerve. It can be sudden, intense, short-lived, or it can linger on. So it varies big time. They can get a sudden burst of pain that's just there and goes, or it can be there for, several hours. So unlike nociceptive, neuropathic includes the opiate and some kind of adjunct therapy. Opiates alone aren't going to do it. And don't freak out. You don't need to write like all of those. It's okay. If they're in your book, it's just important to know that you can't just use you can't just give them morphine and think that the neuropathic pain is going away. They need something along with it, like a tricyclic antidepressant or an anti-seizure medicine. And that's important for your patients to know and to tell them why we're using this different medicine, because you're all going to tell them what medicines they're getting and why, right? So when you give your patient with a neuropathic pain because they have phantom limb syndrome, because they lost their leg in a motorcycle accident, and they're now feeling pain where that leg used to be, and they're in tears, and you say, here's your morphine, and here's your anti-seizure medicine. They're going to look at you and be like, I have seizures. And you're going to tell them that we use that medicine in combination to help treat neuropathic pain. All right? All right. So acute and chronic pain, the differences is based on the cause, the course, the manifestation, and the treatment. Again, remember, I'm going through these a little fast. I know you guys are scribbling. In the future, we don't go. Yeah.
These speeds, it's centrally generated and peripherally generated. You go over anything with that?
They're just the two different types of neuropathic pain. Yeah, I'm sorry. Yeah. Your neuropathic pain can be centrally or peripherally generated. When I make these slides, it takes a long time. So I have to make them on my computer, and then it's basically screenshotted into the program, and then I have to write it out. And when I had made them and screenshotted it, then I realized I didn't have anything to write under them, but I wasn't going back to fix it because it took a long time. So they're just the different types. When I was reviewing what you guys needed to know, we didn't need to go any more in depth. And like I said, I know I am going fast, but you're going to get this again on Thursday. So I just want to cover some key points. So if you're like, oh my God, I'm scrambling. Plus, this YouTube video is going to be posted online right after class. And you guys can watch it and listen to my awesome voice. I've heard it. It's horrible. I feel bad for you all. But you can listen to it as much as you want. The one thing that I forgot to put in there with acute and chronic pain is sometimes you have breakthrough pain. And so this is a rapid onset of pain despite being treated with pain medicines. So it can be acute, it can be chronic, or you can have some breakthrough. So, acute pain, it's a sudden onset. It typically lasts less than 3 months, and as you heal, it starts going away. So, you have a cut on your arm, it hurts really bad, it starts to heal, and after 2 days, it's better, right? It's typically pretty mild, but can be severe. And there's usually something that precipitates the event. I cut myself. I got into a car accident. Someone hit me in the head with a bat. I mean, it's a bit aggressive, but those are different things. And they have physical reactions to it. Their heart rate goes up. Their respiratory rate goes up. Their blood pressure goes up. Think of the last time you got hurt. You tripped and fell. You ran into a door. Think about the way you feel. treatment is typically based just on symptoms and treating the underlying cause. If you have a broken bone, we fix the bone, right? Simple enough. Pain starts going away. And then we give you some pain medicine for that. And as the broken bone heals, your acute pain goes away. But sometimes it can lead to chronic pain. You get into a car accident and you break your back, even though we fix it, some people experience that chronic back pain for life, right? Compared to chronic, it's persistent. But it can kind of wax and wane, right? Sometimes it hurts really bad. Sometimes it doesn't hurt as much, but that pain is always there. So that person that got into the car accident, that now has back pain, sometimes when they're more active, they went to Disney with their family and they walked around a lot, so now their back pain's really, really horrible. But when they were pretty sedentary at home, the back pain was there, but not as bad. They may not know the cause. So unlike acute pain where you typically know what caused it, sometimes with chronic pain they don't know why. It can be gradual or sudden. It could be, we know that bending over hunched, that's why people get back pain. But maybe they had the greatest posture ever and they exercise and they're fit, but they still have back pain. We don't know why. With acute pain, you get kind of physical symptoms that happen to like your vital signs, for lack of a better term. You have that immediate response. Your heart rate goes up, anything. But with chronic pain, it affects them emotionally as well, right? They get really withdrawn. They're anxious. They're depressed. Everybody has that somebody or knows somebody or has met somebody that all they do is complain, right? And they're always hurt. They're always not feeling good. It's hard to be friends with that person. It's hard to be in that person's life. And they realize that they're that person. And it sucks. So they start withdrawing. And they get tired of it. They don't want to move as much because they tried to go to Disney with their family and it hurt. So I'm not going to Disney anymore. So they just kind of don't do as many activities. And everyone's had that, the less they do. I know everyone needs that rest. Everyone likes a good day on the couch with a TV show, a nice binge, Netflix, whatever. But you don't feel great after those days, right? Maybe you do, I don't know. Our goal with them, unlike with acute pain where we can give medicines and treat them, with chronic pain, we're just trying to control the pain. It's not as much treatment. And we want to enhance their quality of life. We want to make them comfortable so that they will go out and do the activities with their family. So what are the pain management principles? I believe this is table 9.5, unless I did it wrong. For anyone following along? It is the 5th vital sign. We want to know what worked, what didn't work. We gave them morphine, they felt better. We gave them morphine, it didn't do squat. We gave heat, we gave ice. We got them up, we kept them down. What helped? Treatment is based on the patient's goals. What does the patient want? What are the patient's beliefs? What are their attitudes? What are their expectations? Is their expectation that I just need you to control my pain enough so that I can do my job? Or I need you to take all pain away. My older sister jokes that if she ever were to get pregnant, she needs to be sedated for the entire pregnancy to have a baby. My expectation was I knew it was going to hurt, but I didn't matter. So it's different for everybody. And so that's going to help guide your treatment. There are drug and non-drug therapies. And you're going to use all of it. So they may need something as simple as Tylenol or Motrin. Or they may need morphine. But you're also going to use things like heat and ice and distraction. It's got to be holistic. It's got to be a whole team. You need to consider things like scheduling. If you have their medicines when they can't take them, or you tell them you're going to take your morphine every day at 8 a.m., and then they're going to go drive that Mack truck with all that, that's not probably a great idea, right? So, and evaluate whether it's effective or not. So there's 3 categories of meds. And this is what we're going to want to focus the most on. That's non-opiate, opiate, and adjunct. So we can treat with meds from one of these groups, or from all of these groups, or 2 of these groups. So we'll start with non-opiates. These are effective for mild to moderate pain. They basically help lower the pain scale, right? So your patient says, I have a pain of 6 out of 10, or I have a headache, and that headache makes me a 6 out of 10. I take ibuprofen, my headache is gone, my pain's now a 0 out of 10. But they often have a ceiling. You can only give so much before they don't start working, right? So it doesn't matter how much you give, it's still not going to have any effect. These don't produce tolerance and addiction. They don't have a ceiling. So people, it's not like people need more to get the same effect. You can take 4 grams of ibuprofen. It's not going to do you any better than probably 600 to 800 milligrams, right? So people aren't overdosing on ibuprofen. They only get so much effect, right? So they don't really tend to have tolerance or addiction issues. They're oftentimes over the counter, so people really need to be careful. When you're taking histories and they're on Tylenol and cold medicine that contains Tylenol, they oftentimes overlook that. So they can end up being, so you have this patient and you're looking at their LFTs, their liver function tests, and you're like, why are they so elevated? And you review their medicines with them and they only give you your prescription. You say, can you tell me some of your over-the-counter meds? Make sure you include that in your history. That's just as important because you can get a whole slew of stuff over the counter. Plus, there's herbal medications. Now there's drinks and everything else. So people can often overdose or have reactions. Opiate sparing effect. They're basically, what that means is they're used with opiates because they allow for effective pain relief and the opiates need a lower dose. So let's say your patient has pain, you're giving them 5 milligrams of morphine, and now you can give them a dose of Tylenol and 2 milligrams of morphine and still achieve the same effect. That's important because when we talk opiates, they don't have ceilings. They do develop tolerance and addiction. So this opiate sparing effect is really important. We can use them in adjunct so that we can help control pain better. I'm going to give you some examples. Aspirin, often used for mild pain, but there's a higher risk for GI bleed. Tylenol. It's used for pain and fever because of its antiplatelet and anti-inflammatory effects. I'm sorry, it does not have antiplatelet or anti-inflammatory effects. I'm sorry. It's metabolized by the liver. And again, it's often used with opiates because it can help with that opiate sparing effect. So just in case you've missed it, I meant no antiplatelet or anti-inflammatory. When we talk about ibuprofen, Motrin, they do. Tylenol does not. So why are these things important to you? Are we going to ask you, when should you not give a patient Tylenol? No, you're past that, right? Because your patients aren't going to come in, and that's not what you're going to see. You're going to see that example that I just talked about. You're going to come in, and your patient's going to have LFTs that are 5,000. And everyone knows what LFT is? If you don't, it's okay. But liver function tests, you're going to have a patient that comes in with liver function tests that are 5,000. Are you going to give them Tylenol? No, because it's metabolized by the liver. We know we have a liver issue. So that's why this stuff is important to know. If we have a person that has a recent GI bleed, are we going to give them aspirin? No. So that's why when you guys are kind of mapping out how you study, it's really important to know the why behind what you're doing it. Know the normal so that you can figure it out. If you just memorize, you're not going to get anywhere. You have to do more than memorize. You have to understand it. And when you guys do things like practice questions, don't just do, and I was talking with another student about this, but don't just like take an answer and say, oh, okay, I see why that's right because of the liver. Go back and look at why the wrong answers were wrong. I will do some Kahoots with you guys, and that's what we do. We talk about why the wrong answer is wrong so you can figure it out and point that stuff out. Our jobs as nurses is to kind of put the pieces together. All right, NSAIDs. It's kind of like aspirin, but it has better efficacy. It works better. But again, because it's like aspirin, they have some GI risks, some renal risks, some hypertension risk. So again, like we were talking about, like a patient with aspirin, patient with NSAIDs, you have to be careful. If that patient has something like peptic ulcer disease, which you guys talked about in level 3. Do you remember that far back? All right, in adult nutrition, maybe. You have to be careful. You may need to use something like a PPI in order to give them. Everyone know what a PPI is? Okay. Careful if a patient has like peptic ulcer disease. Like, so if they have a GI bleed or they have any kind of gastritis or anything that, you know, that's going to involve their stomach, if we're giving them something that's going to cause stomach side effects, all right. We spent some time on that slide, right? Okay. I might want to review it. Opiates. So opiates get really confusing when you look at like how they work because they are categorized by the physiological action. So whether they help or fight against it. So agonist versus antagonist, right? And where they bind. So there's a specific receptor in the body and they bind to it. Everyone, mu, kappa, delta. That is way beyond what we need you guys to know as novice nurses, okay? So the book will go way in depth into that. And if you're going to be on the pain management team, you may want to focus on that better because different types of patients have different needs, but for your guys' sake, your novice nurses, we don't need to go that much into depth. It is important to know that they don't have a ceiling. Makes them different from non-opiate meds. And they can be used for acute or chronic pain, but it tends to be more severe, moderate to severe pain. There's lots of examples. Morphine, oxycodone, codeine, methadone, tramadol. There's a whole slew of them, right? And unfortunately, unlike when we talk about like beta blockers where they're all OL, there's no real way to figure out what belongs to what. Unless you get way into it. Side effects, constipation. This is the most common side effect with opiates because it slows down that GI paralysis and they get constipated. So it's really important, again, so you as the nurse, you're starting your patient who is just in a car accident and is not super mobile on some morphine for their broken bone. What are you going to recommend? Colace, good, right? Because you see that that's missing from the MAR. Those are the type of things that we're going to be looking is to see that you're critically thinking, that we're giving you a scenario that your patient was just involved in an MVA and has recently started on morphine. What is the most important thing that you as the nurse are going to make sure the patient's on, right? Or like that they have increased ICP. So you know that we don't want them to strain because they're on an opiate, so we're going to give them Colace. So you see how you just had to process through real quick the picture and then put it together. That's where we're going to be guiding you guys to. Nausea, vomiting, antiemetics are really important. If they're hurting and every time they're hurting, we give them a med that makes them sick to their stomach and they throw up, is that person going to want to take that med? Especially, let's cut into your stomach, give you an opiate to treat that pain, then we're going to make you sick and you're going to vomit and mess up that surgical wound or surgical incision. So we have to be very careful. We treat the nausea and vomiting. Sedation. This is a big fear, right? If I take too much, it's a big reason why when we were talking about hospice, people were afraid to give pain medicine because we don't want to hasten the death or make them not breathe. It typically only happens with those who are at risk for some kind of sleep disorder. Like if they have sleep apnea, then they may be at more risk for like sedation or decreased respiration. But normally it's not an issue. And with most opiates, we have what? What? Oh, yeah, but I'm sorry, I'm blanking on the word now.
Side effect.
No, we have something to work against it. What? Not like an antidote. That's what I was thinking in my head. Yeah, but we have, typically, people get concerned. We have, I'm blanking, like Narcan. All right, something like Narcan. Not all of them have it, but some of the opiates have medicines that we can give to kind of take away the effects so that if we are seeing some respiratory depression, if we are seeing too much sedation, we can titrate the dose, give less, or give something like Narcan to reverse it. Not all meds, but some.
Antidote.
I don't think it's antidote. I don't know. It's not that important. It's just bothering me. I can't think of it. All right, pruritus. All right, they get really itchy. And some of them will scratch their skin raw. It's more common when they get an epidural. But again, if you notice that your patient that was just put on a opiate and their skin's all excoriated, you as a nurse is going to note, okay, I need to get skin team involved. I need to treat them. I need to make sure that they're on an antipyretic. Again, that's going to be an example. You walk into your patient's room and notice scratches on their arm. They were recently put on a, opiate. What is your action? All right, adjuncts. I'm going to go quickly over these. There's a whole slew of it in your book. And there, we talked about this a little bit. These are used typically with an opiate to help with different types of pains. They can sometimes be used with non-opiates too. But things like corticosteroids, what do? Decrease inflammation, antidepressants, anti-seizure meds. Especially, antidepressants we use a lot with neuropathic pain. Anti-seizure meds are often used with chronic pain. There's GABA receptors agonist and alpha-2, local anesthetics, and the popular marijuana that's being debated right now. I'm not here to promote or whatever, argue it. So that's why I'm just going to go quickly. Some non-drug therapy, again, I'm going to go quickly. They're important because it helps decrease the dose that we need to minimize and helps minimize side effects. So if we can use things like massage, exercise. Has everyone seen a TENS machine? They're like the little electrodes. If we can use heat and cold, if we can use cognitive therapy, if we can use these things to help decrease the amount of med they're getting, we can also help decrease the amount of side effects they're getting from those meds. And it really helps the patient feel like they're in control of it. Like if I know when I tweak my back, if I close my eyes and take 3 deep breaths, the pain starts to subside, that's something I'm controlling. I have control over this issue instead of feeling like the pain runs my life. Because those patients with chronic pain, they feel like they have no control over it. They're frustrated. That's why they get depressed and anxious. So we talked about what are some of the barriers? The first thing is tolerance. So does tolerance happen with non-opiates? No, right? Does it happen with opiates? Yeah. So it occurs with chronic exposure to a variety of drugs. So basically you need a higher dose to maintain the same degree of pain control. I used to take 2 milligrams of morphine for my back, and now in order to get the same pain control, I need 3 milligrams. So if they start to develop some tolerance, the best thing to do is start rotating the drugs. Change it to Dilaudid. Change it to something else. Maybe add a non-opioid. But obviously that drug, for whatever reason, they're developing this tolerance. It's not working as effectively. And they need more and more of it to get the same effect. Is that the same as addiction? I want you all to shake your head no. Dependence. So you have tolerance, you have physical dependence, and this is a normal response to ongoing exposure, manifested by withdrawal when the drug is abruptly stopped. That's why we taper things. So if I'm used to getting this drug all the time, and now all of a sudden we stop it. That's why poor little methadone babies, that their moms were methadone drug users, why the baby was in utero. That's why we don't discharge them home and say, best of luck, little baby. No, we start tapering their dose because they're used to this high dose from utero. And then we take them out and then we give them to them 3 times a day, a high dose. And then we taper the dose down a little bit, and we taper it down, and then it's 2 times a day, and then once a day till none. And we monitor their symptoms. There's this whole scale that they use, and I'm just using infants, but obviously adults too. You know, if they have diarrhea, if they have sweating, if they're crying or irritable. So we monitor their physical symptoms, and we taper drugs accordingly. We just can't stop opiates right away. So tolerance, I need more to get the same effect. Physical dependence is, you stop it too suddenly, I'm going to have a negative effect. We're skipping pseudo-addiction. You guys don't need to worry about it. There's addiction. So this is different than tolerance. It's different than physical dependence. This is a drive to obtain and take substances for other than their therapeutic value or use. So tolerance, I still want it because I'm hurting. I still hurt, I still want it. I just need more of it. Physical dependence is, I don't need it anymore, but if you take it all away from me, I don't feel good. Addiction is, I want it because it makes me feel high. I want it because I can forget about the world when I take it. Tolerance and physical dependence don't indicate that you're going to become addicted to something. Can they follow that path? Yes, but they don't always, right? Most of the time it's not because of that. The hallmarks. It is a compulsive, habitual use. And they have totally lost control of this use. And they can use it despite risk of harm. Your IV drug user who gets hospitalized because of a bad endocarditis immediately goes back on the street and is using again. They need it. It's compulsive. They will do anything. They will sneak it. They will sell, you know, things that they own. They will steal to sell to get money. So tolerance, I need more. Physical dependence, I need you to taper so I don't have negative side effects. Addiction, I'm using it for something other than its therapeutic indication. Something for other than what it's supposed to be used for. And I have this compulsive, habitual obsession to get it.
Does the deal mean disorder? Deal means disorder?
Yes, disorder, sorry. Okay. So a nurse is caring for a post-op client. Which of the following assessment findings is the most reliable indicator that the client is experiencing pain? Blood pressure, pain rating, client grimaces, client refuses to eat breakfast. Who wants A? B? C? D? Anyone abstaining? No. All right. It's B, right? It's whatever the patient says it is. Doesn't matter if they're not grimacing. Nurse is performing a pain assessment on a client. Which of the following subjective data describes the quality? My pain is so bad that I cannot sleep. My pain feels like a tight feeling in my chest. My pain started last week. My pain feels better if I sit upright. Yeah. Everyone like B? Yeah. All right. All right, why don't you guys take... Take another... Oh, here, hold on one second. Miss Lewis, come here real quick. Hold on. So you're recording? You hit stop recording?